Good evening, students. Welcome to you from Sri Rama Hospital, Jagapet. We were discussing about the treatment of chronic peptic ulcer. In yesterday's class, we learnt about the surgical procedures. So one of them is the vagotomy. So it was aimed at cutting the vagus nerve will remove the cyclic phase of the gastric secretion. Thereby, one can achieve about 40% of acid reduction. We learnt about the anatomy of the vagus. In the abdomen, it is mainly supplies the stomach, the posterior vagus. It gives a branch to the celiac plexus, and through that branch, it supplies to the rest of the alimentary tract. There is nerve of Latarjet, which supplies side branches to the body and fundus, and terminal branches to the pyloric antrum. Now, with this brief review of anatomy, let us go to the vagotomy. Vagotomy means cutting the vagus nerve. The types of vagotomy being truncal vagotomy, where the main trunk of the vagus is transected, selective vagotomy, and highly selective vagotomy. So there are three types of vagotomy. What is truncal vagotomy? So we have seen the vagus nerve enters the abdomen through the esophageal hiatus. One nerve coming anterior to the vagus, that is called the anterior vagus. Another one coming posterior to the esophagus, that is called the posterior vagus. If you cut the vagus nerve just below the esophageal hiatus, before it has given any branches, that is the main trunk. So that is called the truncal vagotomy. So both vagus nerves are sectioned below the esophageal hiatus. Effects: because the stomach gets completely denervated from parasympathetic innervation. Not only stomach, even rest of the gut also loses the parasympathetic innervation. Because the branch going to the celiac plexus, it supplies to the small bowel as well as to the large bowel. So because of that, there will be some amount of dysmotility of the small bowel, and that can lead to flatulence, diarrhea, and dyspepsia. And even the gastric motility is also affected, because vagus nerve is a parasympathetic nerve. It is not only secretomotor but also motor to the stomach and rest of the viscera. Of course, the motility of the gastrointestinal tract is influenced by three methods. What are they? What are the three systems that influence the gastric motility? Very good. The three being the extrinsic innervation by the parasympathetics and sympathetics, the intrinsic nervous system, that is called the enteric nervous system, and the third one is the neuropeptide hormones secreted by the various structures in the alimentary tract. So all these things that influence the motility. So when the parasympathetic, which is the main motor nerve to the alimentary tract, is denervated, the motility of the stomach as well as rest of the alimentary tract is affected, though not abolished. It is not abolished, because still the two other mechanisms are intact. So it is not abolished, but it gets altered. So the motility of the stomach is affected. That is why there will be improper emptying of the stomach with gastric stasis and distension. To overcome this problem, whenever you do vagotomy, truncal vagotomy, you must always club it with a drainage operation. Drainage operation means the stomach contents can easily be delivered into the duodenum or small intestine. So that is done by either by cutting and opening, enlarging the opening of the pylorus, that is called pyloroplasty operation, or by diverting the food into the small bowel, that is called the gastrojejunostomy operation. So whenever you do truncal vagotomy, because the stomach's motility is being affected with the resultant gastric stasis and distension, the another operation to drain the stomach is performed, that is pyloroplasty or gastrojejunostomy. So to avoid this problem of postoperative diarrhea or flatulence because of intestinal motility disorder, the surgeons later started doing a procedure called selective vagotomy. In this selective vagotomy, what they do is, now you can see here, this is the nerve of Latarjet. The nerve of Latarjet is coming, it is giving hepatic branches from the anterior. It is giving celiac plexus branch from the posterior trunk. So you leave the celiac plexus branch intact, transect only the nerve of latar jet. That means the nerve supplying the stomach only is cut, both the anterior one as well as the posterior one. With that, what you are doing, you are preserving the hepatic innervation as well as the celiac plexus innervation. So the motility of the intestines is maintained. That is why there is no question of any dyspepsia or indigestion or flatulence or diarrhea. So this is called, you are selecting the vagus branches going to the stomach. That is why it's called the selective vagotomy. Both the vagus nerves are sectioned after the hepatic and celiac plexus branches. Celiac branch is preserved, so there is absence of diarrhea. Gastric motility and emptying is still affected because the whole of the stomach is being denervated from parasympathetic supply. Hence, a drainage procedure is needed for this procedure also. Then third procedure is called the highly selective vagotomy. Highly selective vagotomy means now we have seen that the vagus nerve becomes the nerve of latar jet. The nerve of latar jet gives off branches to the body and fundus, and it ends by 3 terminal branches in the pyloric antrum. In the physiology of stomach, we have learned that stomach is having 2 parts physiologically. One is the body and fundus, which secrete acid. The antrum. The antrum doesn't secrete acid. Motility wise, the body and fundus, they have receptive relaxation. Whenever food is taken, they relax and they become a large funnel-like. They accommodate the food. The antrum, it is in contrast to the fundus and body, it vigorously contracts. It causes propulsive action as well as mechanical grinding of the food. So this antrum is also called the antral mill. Like a mill, it works to pulp the food. So there are 2 distinct entities in the stomach. One is secreting acid, the other concerned with emptying of the food through pylorus as well as grinding of the food with proper motility. So that is why 2 surgeons called Andrew and Jensen, what they thought was, instead of cutting the vagus nerve totally, if those branches going to the parietal cell area, that means to the body and fundus, if we cut only those branches and leave the terminal branches intact, that means the branches going to the pyloric antrum, if they are left intact, then what happens? The antral motility is maintained, the mechanical action of the stomach is maintained, the proper emptying of the stomach is maintained. So there is no question or there is no need for doing an additional drainage operation. This is called the highly selective vagotomy. So you are highly selective toward the parietal cells. That is what is also called as parietal cell vagotomy. So it has 2 names. One is the highly selective vagotomy, other is the parietal cell vagotomy. There is third more name that is called the proximal gastric vagotomy. That means only the proximal part of the stomach innervation is being denervated. So the branches to the body of the stomach and fundus are alone divided, reducing the acid secretion and preserving antral branches. It is also called as proximal gastric vagotomy or parietal cell vagotomy. Advantages: no need for a drainage procedure, and hence its sequelae, dyspeptic symptoms, bilious vomiting, etc. are absent. Disadvantages: the criminal nerve of Gracie may be missed and cause high recurrence rate. Now you can see here, there is one nerve coming most proximally from the vagus nerve. This nerve actually traverses over the esophagus and passes to the fundus and supplies the only fundus area. When you are doing highly, if you don't clear the branches which are passing from the vagus nerve towards the stomach, face of the esophagus. So if you don't clear these particular branches, you are likely to miss this nerve. So even if one nerve going to the fundus and body is missed, then there will be parietal cell stimulation and there is more acid secretion. So the patient will get recurrent ulceration. That is why in the initial phase of this particular procedure, so many surgeons performed it, but they got a lot of recurrence. That's why this has gone into disrepute. Then the originators of this procedure, they investigated these cases and then they came out with this called the criminal nerve of Gracie. That means this particular branch, if it is missed, then the patient is going to get the recurrence rate. So whenever you are doing highly selective vagotomy, you must look for this criminal nerve and you must section this nerve also. Then the patient will get good benefit. So this is the nerve which is going over the esophagus into the fundus. So when you cut only these nerves on the lesser curvature and you miss the nerve going on the esophagus, so there is a chance of having the recurrence. Truncal vagotomy and HSV is now performed laparoscopically. Yes, celiac plexus sends mostly the sympathetic nerves to the stomach. It doesn't send the parasympathetic nerves to the stomach. The parasympathetic exclusive supply is through nerve of Latarjet only. They do not come through the celiac plexus. The branch that is going to the celiac plexus, the vagal fibers gets distributed through the rest of the alimentary tract other than the stomach. The drainage operations, there are two. One is the gastrojejunostomy, which can be done on the anterior side or posterior side. The other is the pyloroplasty. These are not effective as a sole procedure as the main cause of ulcer is not dealt with. Hence, these procedures are performed as a complementary to truncal vagotomy or selective vagotomy. Gastrojejunostomy. You can see here, this is the stomach, this is the duodenum. Duodenum is passing retroperitoneally like this, and this is the duodenojejunal junction. So the most proximal part of the jejunum is anastomosed to the posterior wall of the stomach. So the anastomosis is done on the posterior wall. It is done vertically. That means the jejunum is placed vertically on the posterior wall of the stomach and anastomos. It can be placed horizontally, it can be placed vertically, it can be placed obliquely. But the preferred position is the vertical position. Then it is behind the transverse colon. It is isoperistaltic. Isoperistaltic means the peristaltic waves of the stomach go down like this. The jejunal peristalsis go down like this. That means both of them are in the same direction. So the jejunal loop is arranged in such a way that its peristaltic waves also pass in the same direction as that of the stomach. So that is called isoperistaltic. But if you keep the jejunal loop in the reverse way, then what happens? The jejunal peristalsis will be going upwards, stomach will be going downwards. Then that is called anti-peristaltic anastomosis. That is never being done. So you go for isoperistaltic, no loop. If you leave behind some part of jejunum here and anastomos, so there will be sagging of the jejunum here. So that forms a loop there. Whenever loop is there, there will be some complications. So you must do the anastomosis in such a way that there is no loop formation in the jejunum. So this anastomosis is described as posterior, vertical, retrocolic, isoperistaltic, no loop, jejunostomy. So the abbreviation for this is PV ring anastomosis. PV ring. That is how you can remember this. This is a commonly done procedure. You can also do the anterior gastrojejunostomy, but for duodenal ulcers, you don't do the anterior gastrojejunostomy. Then pyloroplasty operation. To do gastrojejunostomy, some surgeons they do without doing vagotomy. For chronic peptic ulcer, the duodenal ulcer or gastric ulcer, they do gastrojejunostomy alone. Their contention is that you are diverting the acid from the duodenal area to the jejunum. So the ulcer will heal. That is right. The ulcers will heal if you do simple gastrojejunostomy without having vagotomy. But the problem is the stomach is still secreting more acid. The acid insult will be there now on the jejunum. So now the patient will develop a gastrojejunal ulcer. So the problem of doing simple gastrojejunostomy without doing vagotomy is patients may develop a gastrojejunal ulcer that is also called the recurrent ulcer. Pyloroplasty operation. Okay, someone has asked me about the no loop. I'll explain it a little bit. Now you can see here, this is the jejunum. You are anastomosing like this. Let's suppose this is the duodenojejunal junction. Now this is the stomach. Here is the fourth part of the duodenum, and this is the jejunum. If you do the anastomosis like this, and the posterior wall. That means not very, this is the duodenal junction, this is the junction, this is the free loop of jejunum. If you do not do it exactly just below the duodenal junction, if you keep about some 5 or 10 centimeters of the loop and then you take the anastomosis, then what happens is this forms a loop. So whenever loop is there is a chance of bile collection there and forms the patient develops bilious vomiting. Of course, I will describe more about that when we talk about the sequelae of gastric operations. So in pyloroplasty, what you do is you make an incision on the anterior wall of the duodenum, 2.5 centimeters, and on the pylorocantrum, 3.5 centimeters. So you cut the full thickness of the anterior wall of duodenum and pylorocantrum. So they are cut. Now it is open, duodenum and antrum is open. Now you can see the posterior wall of the duodenum and posterior wall of the pylorocantrum. Then What you do is you hold in the middle and retract them up and down. So a horizontal incision will be now made into a vertical opening. I hope you understood this point. You made the incision horizontally over this antrum and duodenum. After making the opening, you apply a ligature suture here, pull it upwards. You apply a suture below and pull it downwards. So the opening will become diamond shape. Now what you do is you suture it from above downwards. So now the opening has become diamond shape. Now you suture it vertically. So horizontally incision is made and it is vertically sutured. So this is called the pyloroplasty operation. So what is happening here? The pyloric sphincter is being cut, so it becomes totally dysfunctional. The opening has become very wide. So by gravity itself, the food can drain into the duodenum. So this is the idea of doing pyloroplasty following vagotomy operation. Now the gastric hypersecretion is not only because of the psychic stimuli passing through the vagus. They are also because of gastrin hypersecretion. So that is why now people thought that if we remove part of the stomach, then the patients will be losing the antral G cells, so there will not be any G cell stimulation. So that is why the gastrectomy has come into picture. The types of gastrectomy: if you remove the pyloric antrum, how do you define an antrum? You draw a line from the insula angularis straight downwards to the greater curvature. So if you remove this part of the stomach along with some amount of lesser curvature, it is called the hemigastrectomy or antrectomy. If you remove about 65 to 75% of stomach, it is called partial gastrectomy. If you remove about 80% of stomach, it is called subtotal gastrectomy. If you remove complete stomach, it is called the total gastrectomy. So what type of gastrectomy you perform for a duodenal ulcer patients? There are two types of operations. One is called the Billroth 1 gastrectomy. This is nothing but a partial gastrectomy followed by gastroduodenal anastomosis. The second one is called the Billroth 2 gastrectomy. It is also a partial gastrectomy followed by gastrojejunal anastomosis. The first one is the gastroduodenal anastomosis. The second one is the gastrojejunal anastomosis. So both were invented by the great surgeon Billroth, Theodor Billroth. He was a German surgeon and he lived between 1829 to 1895. And 1881, that is a notable year for surgeons, because that year Theodor Billroth has performed first gastric resection. Successful gastrectomy operation was done by Billroth. His scrupulous methods of doing surgery, his anatomical methods of dissection has led him to a great surgeon. These are some of the achievements. Students should know about this great man. He did first successful gastrectomy, laryngectomy, esophagectomy, hindquarter amputation, and he pioneered resection of bowel and bladder cancers. He founded the modern concept of reporting statistics. So how many patients were operated, and how many patients had the troubles, morbidity, what are the complications they have faced, how many have so many complications, all that. So that statistical data recording was started by Bill Roth. Founded the great school of surgeons. That means he was a great teacher. Many surgeons from all over the world used to go to his institute for learning techniques of surgery. And out of them, some of them have become very great, and they are the notable names in surgery. They being Sejourny, Wolfler, Mikulicz, Halsted. So all these names we read whenever we read any subject on surgery. So this is the first gastrectomy operation he performed. So he has drawn the diagrams in his operation notes, how he performed it. So what he did was he removed the pyloric antrum. Then he has sutured the stomach and the lower end. On the lesser curvature side, he made a small opening corresponding to the diameter of the duodenum. And then he performed the anastomosis between the duodenum and this stomach. So this is how he performed the gastroduodenal anastomosis. Bill Roth 1 gastrectomy is the lower partial gastrectomy along with the gastric ulcer followed by gastroduodenostomy. So this particular procedure is done for gastric ulcers. So in the gastric ulcer, the ulcer will be there on the lesser curvature at the incisura angularis. That is why the ulcer bearing area also should be included in the operation. So the lower part of the stomach, distal part of the stomach, that means pyloric antrum, along with the ulcer bearing area on the lesser curvature is resected, followed by anastomosing the stomach to the duodenum. So this procedure is done for gastric ulcer. This is how it is done. So this is the ulcer on the lesser curvature side. So you make a oblique cut on the lesser curvature and a transverse cut at the pyloro body junction, and you transect the pylorus from the duodenum, and you remove this part of the stomach. The upper part is sutured, the lower part is anastomosed to the duodenum. So after many modifications, this is the ultimate way we perform gastroduodenostomy now. Nowadays, this is how we do the gastroduodenostomy, not the original method of Bill Roth. But because this procedure was first started by Bill Roth, so this goes with the name of Bill Roth's gastrectomy. Then Bill Roth 2 gastrectomy. It is lower partial gastrectomy followed by gastrojejunal anastomosis. So you remove the stomach antrum as well as part of the body, and then you anastomose the jejunum upper end to the stomach. This is called Bill Roth 2 gastrectomy. There are modifications for this. So Bill Roth 2 gastrectomy is done for duodenal ulcer. Bill Roth 1 gastrectomy is done for gastric ulcers. You can ask me, in gastric ulcer, why can't we do a gastrojejunal anastomosis? Yes, you can do gastrojejunal anastomosis also. But if you do gastroduodenal anastomosis, the normal pathway of duodenum is preserved. So the duodenal stimulation by food is there, which will cause stimulation of the pancreatic and release of the bile. So there will be proper mixing of the food with bile and pancreatic juice. So there will be a normal digestive mechanism. But if you do the anastomosis to the jejunum, the advantage is it is technically easier. But patient will have some post-meal discomfort because there is not improper mixing of food with the bile and pancreatic juice because directly going into the jejunum. The stimulation of the pancreas is not also adequate in the initial stages. So that is why pancreas secretions are also not coming normally. That is, the patient will have some dyspeptic symptoms after the gastrojejunostomy operation. Then the antrectomy operation, that means removal of the pyloric antrum, when combined with truncal vagotomy, it gives highest recurrence-free rates because when you are doing vagotomy, you are cutting the cyclic phase. When you are doing antrectomy, you are removing gastrin phase. So both phases of acid secretion are being abolished. So there will be marked diminution in the acid production. So in the previous days before the PPIs, this was the favorite operation in USA. So we have seen very many operations. 3 types of vagotomy, 2 types of drainage operations, and 2 types of gastrectomy operations. So which operation you choose for the procedures? So the choice depends upon the age and general condition of the patient, activity of the ulcer, and associated complications of the peptic ulcer. The mortality after any procedure, recurrence rate, post-operative sequelae should be considered before selecting the surgery. So each surgery has its own drawbacks. Some have high mortality, some have high recurrence rate, some have post-operative discomfort to the patient. So you have to balance them by choosing against the age, general condition, activity of the ulcer, and complications in the peptic ulcer. So these are all the various operations: gastrojejunostomy alone, truncal vagotomy plus drainage, highly selective vagotomy plus drainage, truncal vagotomy plus antrectomy, gastrectomy. So these are all the various combination of operations that were practiced. So when you look at the recurrence, gastrojejunostomy alone produced 25 to 50% of recurrence because the acid producing mechanism was not being touched. That's why the patient continues to secrete the acid, so they cause the as someone has asked me whether duodenum will become a blind loop. Definitely, duodenum will become a blind loop. So that's why that itself will produce some problems. So I will discuss all those problems in the post-operative sequelae after gastric operations. So there is one chapter is there. That is the last chapter in this chapter on stomach and duodenum. So in that chapter at length, I will discuss about those problems. So some surgeons, they call gastrojejunostomy is not a surgical procedure, it is a disease. We are making the patient to get relief from duodenal ulcer pain and get the discomfort and dyspepsia of gastrojejunostomy. So gastrojejunostomy doesn't completely relieve the symptoms. The symptoms get altered. So because of the anastomas to the jejunum and because of the improper mixing of the food and improper emptying of the food into the jejunum, so there will be many sequelae and problems to the patient. So those are all called the sequelae after gastric operations. So I will explain all those things there. Definitely, the duodenum acts as a blind loop. So the recurrence rate is about 25 to 50% in gastrojejunostomy. Truncal vagotomy plus drainage, it is 2 to 7%. Highly selective vagotomy, also the same thing. Selective vagotomy, also about 5 to 10%. So vagotomy has about 5 to 10% of recurrence rate. Why so? Because vagotomy deals about only the cyclic aspect, cephalic phase of the gastric secretion. Gastrin phase is still intact. That's why there is some amount of acid secretion which causes the ulceration. Truncal vagotomy plus antrectomy. That means you are abolishing both cephalic phase and gastric phase. That's why patients get only 1% of recurrence. Only gastrectomy, patient has recurrence rate of about 1 to 4%. Post-operative sequelae, that means I told you the disturbance to the patient in the digestion. They are all produced about 10 to 20, but gastrectomy will have highest number of sequelae. About 40% of the individuals, they have the sequelae. Mortality also is there, all around 1%, but gastrectomy carries about 1 to 2% mortality rate. So when you are choosing the procedure, depending upon the patient's condition and ulcer condition, you have to choose the operation. You must always try to achieve no mortality, less postoperative sequelae, and no recurrence rates. So the choice of operation for gastric ulcer being Billroth-1 gastrectomy. It is the ideal operation. Ulcer with the ulcer prone area is removed here. Low recurrence rates. Mortality is about 1 to 2% in thin and frail individuals. Vagotomy, pyloroplasty, and excision of the ulcer. This is advocated in high-risk patients because it can have some recurrence rates. The operation for duodenal ulcer choice, vagotomy and gastric drainage is most acceptable form of treatment when you compare the mortality, postoperative sequelae, and recurrence rates. So it will be in the acceptable range. That's why this is the widely practiced procedure. Post-vagotomy diarrhea is problematical. The proximal gastric vagotomy gives better results in non-stenotic cases. Billroth-2 gastrectomy, because of its high mortality and morbidity, it is reserved for recurrent ulcer and Zollinger-Ellsel syndrome cases. Laparoscopically also you can do the procedures. So these are all the procedures you do. So this is about the surgical management of chronic peptic ulcer. So if you have no doubts, I will proceed to the next topic, that is the complications of peptic ulcer. Do you have any doubts? Well, if you have no doubts, we will go to the next topic. Complications of peptic ulcer, they can be classified into acute, chronic. In the acute complications, the complications can be number 1, perforation, number 2, hemorrhage. The chronic complications be due to fibrosis and cicatrization. They can cause penetration. Due to fibrosis and cicatrization, it can cause stenosis. In case of duodenal ulcer, it is the duodenal lumen that gets stenosed. In case of gastric ulcer, the wall of the stomach gets contracted, producing hourglass contracture or teapot stomach. The treatment for multiple ulcers also the same. But when you find multiple ulcers, you must always exclude the hormonal etiology for the ulcer, like Zollinger-Ellison syndrome, hyperparathyroidism. They must be investigated beforehand. If you don't find any abnormality in the hormones, then you can go ahead with the usual procedure. That means the vagotomy and drainage operation will be adequate. The third complication of peptic ulcer is malignant transformation. That is for the gastric ulcer, not for duodenal ulcer. First, let us discuss about the acute complications, namely the perforated peptic ulcer. Five to 10% of peptic ulcer patients they present with perforation. Commonly affects males. Age is 35 to 45 years. Past history of peptic ulcer dyspepsia is present in about 60 to 70% of the cases. History of NSAID usage is present in many cases, especially in elderly females. So actually this NSAID precipitates this acute ulceration and perforation. Pathology: an ulcer on the anterior wall of the duodenum, it perforates. An ulcer on the posterior wall of the duodenum, it penetrates, producing hemorrhage. So anterior wall ulcers, they perforate. So when they perforate, what happens? The stomach contents and duodenal contents, they leak into the peritoneal cavity. So what are the contents of the stomach and duodenum? The gastric juice, the bile, and the undigested food material, along with the air that is present in the stomach and duodenum. So these things, they contaminate. So air, fluid, and food escape into the peritoneal cavity. So what will happen? First stage is called stage of peritonism or peritoneal irritation. Sudden gush of irritant material, that means acid is irritant, food is irritant to the peritoneum, bile is irritant. So whenever there is sudden gush of these materials into the abdominal cavity through the perforated ulcer, which is there in the duodenum or stomach, there will be intense irritation to the parietal peritoneum. Parietal peritoneum, is it a somatic structure or a visceral structure? Parietal peritoneum, is it a somatic structure or a visceral structure? All of you please answer. I will just check how much you are following the anatomy. One has mentioned it is visceral structure, all the remaining has mentioned somatic. What about others? Please give your opinion. Is it somatic or visceral? Okay, it is a somatic structure. It is not visceral structure. Visceral peritoneum is the visceral structure. Parietal peritoneum is the somatic structure. That is why whenever parietal peritoneum is irritated, patient gets severe pain, which is well localized. It is not diffuse pain. It is well localized severe pain. And that also will cause overlying muscle spasm. That is why abdominal muscles over that parietal peritoneum goes into spasm. So the patient gets severe and sudden pain in the upper abdomen. Sometimes the pain is so severe, immediately after perforation, the patient says, ah, and then with such a severe pain, he gets into neurogenic shock and he falls down onto the ground. So much of severe pain will produce whenever sudden gush of acid is occurring, splashing onto the parietal peritoneum. So the severe pain can produce neurogenic shock. Patients, when you examine the patient during that state, you will find him to be having pale, anxious face with tachycardia and low volume pulse. The peritoneal irritation can lead to reflex spasm of the abdominal muscles, producing board-like rigidity of the abdomen. Still, there is no bacterial contamination of the peritoneal cavity. There is only chemical reaction, chemical irritation by the hydrochloric acid and bile on the peritoneal cavity, producing this irritation. So whenever peritoneum is irritated, what will it do? It secretes fluid. So it secretes copious fluid. This fluid will neutralize. So after 3 to 6 hours, peritoneum secretes copious fluid to neutralize the leaky gastric contents. So because they have been diluted, irritants have been diluted, so pain also is diluted. So there is reduction of peritoneal irritation, so there is reduction of pain. So there is relief of muscle guarding, there is relief of pain. But there is distension of abdomen due to the presence of fluid in the peritoneal cavity. But that is mild. So patient first initially thinks that he had a very severe problem. He prepares himself to come to the hospital. So when he arrives at the hospital, then within 10 minutes or within half an hour or within 1 hour, his pain gets relieved. Then he will say that, yes, I am now completely normal, I will go back to my home. He demands even that. But the examining doctor should take into consideration that what the problem is. Unless he knows that this stage is there, he can miss a perforation. How not to miss a perforation? You go with the pulse rate. So in the second stage, though the pain is reduced, but the pulse rate is still rapid. So a rapid pulse rate and persistent rapid pulse rate or increasing pulse rate always denotes some pathology in the patient. Though the patient feels comfortable, you should not leave the patient. You must investigate the patient to know the interior cause. So please remember this. So whenever an acute pain abdomen patient comes to your clinic, you have to focus on the abdomen, that is true, but you must also examine and count the pulse rate. So pulse rate counting means don't count for 5 seconds and multiply by 12 and get the result. Don't do like that. You count the pulse rate for 1 whole minute and record it. And every 1 hour later, you record the pulse rate and see the changes. If there is increasing pulse rate, means the pathological sequence is still worsening in the patient. So pulse rate is very, very, very important clinical parameter. So in spite of deceptive improvement in the patient's condition, the pulse rate increases progressively. As the stage masks the features of perforation, there is pain and guarding. This stage is also called as stage of illusion. Then third stage is called stage of bacterial peritonitis. After 6 hours, due to peritoneal irritation, there is reflex inhibition of gastric acid secretion. Initially, why there is no bacterial contamination of the peritoneal cavity? Though there is a perforation, the reason is the gastric acid kills all the microbes. That is why sterile hydrochloric acid is gushed into the peritoneal cavity through the perforation. So it is a chemical reaction. After few hours, what will happen? Because there is peritoneal irritation, the underlying viscera, they undergo physiological paralysis. They don't do their functions. So there is lack of motility and there is lack of secretion. So as the secretion is diminished, hydrochloric acid diminishes in the stomach, so then the patient is swallowing. So whenever he swallows, the oral bacteria comes here. As the gut is dilated, the bacteria, they will now pass antegrade. Normally they should pass downwards towards colon. Now they go in a retrograde way towards the oral cavity. So that's why they come to the duodenum and then pass through the perforation and they enter into the peritoneal cavity, produces bacterial peritonitis. So proliferation of bacteria in the stomach which have entered from the oral cavity and later from the intestines. Migration of bacteria through the perforation of the peritoneal cavity, producing bacterial peritonitis. The causative bacteria being Pseudomonas, Klebsiella, E. coli, and sometimes Candida albicans. What will happen in peritonitis? Copious peritoneal fluid secretion. So due to bacterial infection, peritoneum secretes a lot of fluid. And due to peritonitis, there will be reflex paralytic ileus. So the fluid that is there in the intestines is not absorbed, that gets sequestrated. So there is fluid accumulation in the peritoneal cavity and there is fluid accumulation in the intestines. So ultimately what will happen? Both will produce hypovolemia and shock. So patient gets the features of shock. This shock can lead to MOTS. So peritonitis produces hypovolemic shock. Though there is no external loss, the loss of fluid is there in the body itself. So this is called the third space loss. Apart from this fluid loss, there is one more problem with the bacterial peritonitis. That is, the toxins liberated from the bacteria, they are absorbed by the peritoneal membrane. They lead to sepsemia. Whenever there is sepsemia, sepsemia produces three phenomena. Number one, increased third space loss. Why there is increasing third space loss in sepsemia? Already we discussed this point when we discussed about shock. Why is there increased third space loss in sepsemia? Not only sepsemia due to peritonitis, but any sepsemia, there will be third space loss. Why? Where does sequestration will be there? Sequestration of fluid as where? In the interstitial spaces. You are right. Why? Why there is interstitial space fluid sequestration? Why? Yes, very good. Due to vasodilatation. There is generalized vasodilatation and generalized fluid exudation from the capillaries. That causes interstitial fluid sequestration and that causes, again, third space loss. And in sepsemia, the toxins, bacterial toxins, they produce cardiac depression. So it causes decreased cardiac output. In sepsemia, there will be altered ventilation perfusion in the lungs. So there will be pulmonary dysfunction leading to hypoxia. So this will produce the MOTS. So peritonitis, bacterial peritonitis can cause two problems. Number one, fluid sequestration in the peritoneal cavity, fluid sequestration in the intestines, fluid sequestration in interstitial spaces due to sepsemia. And added to that one, the bacterial toxins can cause decreased cardiac output, hypoxia leading to MOTS. So there will be marked by multiple reasons. Clinical features of bacterial peritonitis. There will be features of hypovolemia due to dehydration and shock. There will be features of sepsemia, producing fever, tachycardia, tachypnea. The severity is very high after 48 hours, causing high mortality. Local features. There is distension of abdomen due to peritoneal exudation and associated paralytic ileus. There is guarding, which is like a board. The abdominal wall feels like a board. So these are the features you will find in the bacterial peritonitis. So how the patient presents to us? There are three types of presentation. One type is called the classical type. In the classical type, the three stages just now described are seen. That means initially there will be stage of peritoneal irritation, and later there will be stage of peritoneal reaction by producing fluid accumulation causing diminution of the symptoms and signs. And third stage, the patients will get bacterial peritonitis after 6 hours. So these are the three phases. If they are present, we call it as a classical type of clinical presentation. Less dramatic. This type occurs in elderly people who are taking NSAID drugs. So there, because of the influence of the NSAID drugs, they manifest with lesser pain and lesser rigidity. And because older people, their abdominal walls will not have so much strength and tone. That is why there will not be so much rigidity. The third type of presentation is presenting as acute appendicitis. How acute appendicitis presents? Tell me. In one of the classes, in the beginning of the classes, I told you the clinical manifestations of acute appendicitis. How the symptoms manifest. That is, first initial symptom is the pain. How the pain presents in acute appendicitis. Where it is felt first, and later where the pain is felt. Yes, very good. In acute appendicitis, first the patient presents with the pain in the umbilical region. After few hours, he gets the pain in the right iliac fossa. This is called the shifting pain. Pain shifts from one area to other area. So this is called the shifting pain. Now, in some cases, where the perforation is very small and where the fluid discharge from the stomach also is not as a gush, there is slow leakage is there. Then what happens? First there will be, due to perforation, some fluid accumulates in the right hypochondrial region. So the initial complaint of the patient will be pain in the upper abdomen. After few hours, what happens? Because the leak is very small, the fluid goes into the paracolic gutter. Paracolic gutter means the space by the side of the ascending colon. So it goes by the side of the ascending colon in the gutter and comes down due to gravity. And it accumulates in the right iliac fossa. And this fluid now irritates the peritoneum in the right iliac fossa. So now the patient complains of pain in the right iliac fossa. So this is shifting pain. So initially the patient will have pain in the upper abdomen. Few hours later, he develops pain in the right iliac fossa. So that is called shifting pain. So that is why then you may mistake it for acute appendicitis. The fluid may track from perforation via the right paracolic gutter into the right iliac fossa and causes irritation of parietal peritoneum, resulting in pain and guarding in the right iliac fossa. And fourth variety is the subacute perforation, where perforation is very, very small, just like a pinhole. when such a small pinhole is there, what happens? There will be 1 or 2 bubbles of fluid that is coming out, not gush of fluid. So just 1 or 2 bubbles that causes local inflammatory reaction. So because of the local inflammatory reaction, the momentum and other structures, they come and seal it due to fibrinous adhesions followed because of local acute inflammatory reaction. So that 2 or 3 or 4 bubbles which has come out, they get surrounded by fibrous adhesions and that collects inside. So that later gets infected and forms an abscess. So the abscess forms by the side of the duodenum. That is what is called the paraduodenal abscess. So if the perforation is small, it gets sealed by inflammatory adhesions to the neighboring organs and to the greater momentum. So then the patient will have mild pain, mild guarding, making the diagnosis of perforation difficult. So he may develop abscess or he may not develop abscess. If it is just absorbed, the patient may not get abscess. Otherwise, he gets mild pain and then afterwards it subsides. Differential diagnosis of perforated peptic ulcer. All acute abdominal conditions should be considered. The common acute abdominal conditions being acute appendicitis, acute cholecystitis, acute pancreatitis, superior mesenteric ischemia in older people producing midgut gangrene, acute intestinal obstruction, and enteric perforation. Of course, I have mentioned only few. Chest diseases, myocardial infarction, basal pleurisy, consolidation of the lower lobe of the lung also has to be considered. In myocardial infarction, the patient gets severe pain in the chest or lower chest, and he may faint. Similarly, a patient with perforated peptic ulcer may get severe pain in the upper abdomen and he may faint. So that's why you have to differentiate between these 2 conditions. And you have to differentiate from other medical conditions like preherpetic neuralgia, hepatic crisis, diabetic crisis, acute porphyria, where the patient will have the severe pain in the upper abdomen. Investigations: plain X-ray abdomen or chest in erect posture. Why to take the patient X-ray in erect posture? Because air goes by anti-gravity mechanism. So whenever patient stands erect, the air always floats upwards. So if you take a normal X-ray of the abdomen, for normal abdomen, you will see this dome of the diaphragm like this. Under that, you won't see this black shadow. Black shadow indicates air. Normally, there is liver here. Liver is a solid organ. It won't cast any shadow. Because there is no gas, you won't see anything. So the lower part of the lung is considered as the diaphragm, normally. But when air escapes in the peritoneal cavity and when patient stands, now the air now goes between the liver and dome of the diaphragm. So air always casts a black shadow. So you can see here a black shadow. And this shadow will have the lower border is crescentic. It's like this. If there is some fluid and air, both are there, for example, then what happens? The shadow will have a horizontal border. It will have a border horizontal. So air under the domes of the diaphragm seen as a crescentic air shadow. So whenever this X-ray is shown to you in your Viva house, you must always say crescentic air shadow is seen under the dome of the diaphragm. You must mention that. Simple air shadow is also correct, but if you say crescentic air shadow, that gives more weightage to your answer. It is seen in more than 80% of the cases. I will tell you a few points about this pneumoperitoneum, that means air in the peritoneum. 5 ml of air is needed to cast a shadow on the X-ray. If a small perforation and patient leaks only about 1 to 2 ml of air, then air shadow is not seen. Some of the fancy examples will be there. They'll be asking all these silly questions. That is why I am putting all this data here. The other causes of pneumoperitoneum, apart from perforated peptic ulcer, the other organs perforation also can produce pneumoperitoneum. There is perforation of the other viscera due to trauma, disease like enteric fever, appendicitis, ulcerative colitis, penetrating malignant ulcers. And pneumoperitoneum can be there following diagnostic procedures like tubal insufflation test and laparoscopy. You know, in laparoscopy, you have to inflate air into the peritoneal cavity. That is why after laparoscopy, if you take an X-ray, you will definitely see a crescentic shadow under the dome of the diaphragm. That is normal. All this air to get absorbed, it takes about 6 hours to 2 days. In some patients, it gets absorbed fast. Some patients takes more time. Tubal insufflation test. Probably all of you know about this tubal insufflation test. If you don't know it, just I will tell 2 points about that. Do you know it? Tubal insufflation test? Yes or no? Okay. Tubal insufflation test is done to know the patency of the fallopian tubes. If a woman comes to the gynecologist for investigation of infertility, the infertility can be due to tubal block. So whether the tubes are blocked or not, or due to ovarian dysfunction, or due to hormonal disturbance, or due to some uterine pathology. So they have to investigate that. So to exclude tubal problem, what they do is they do pervaginal examination. They find the cervix. Under the cervix, they pass a fine catheter into the uterus. Then this catheter is connected to a small bulb and air is inflated. This air will go into the uterus. Then from there, it passes into the tubes. From the tubes through the femoral ends, they will escape into the peritoneal cavity. So what they do is they keep a stethoscope in the right iliac fossa and they inflate. So when they are inflating, the hissing of air leaking out from the femoral end can be heard through the stethoscope. If such is heard, then they say that the tubes are patent. If that is not heard, then they say the tube is probably blocked and requires further investigations. So this is called tubal insufflation test. After you take an X-ray after the tubal insufflation test, you will notice air in the peritoneal cavity as a crescentic shadow under the dome of the diaphragm. After laparotomy also, if you take the X-ray, then air will be seen. After any abdominal surgery, air gets entrapped inside the peritoneal cavity and it takes 5 to 7 days to get absorbed, and during that time, if X-ray is taken, it shows the pneumoperitoneum. Next is another X-ray. As first steth is kept in the right iliac fossa and you inflate and you hear. Confirm whether right side is air hissing is heard or not. Then you place the stethoscope on the left side and then you press the bulb and check whether air is coming out through the left tube or not. So independently you do it, not at the same time. First you keep it on one side, then on the other side. This is another X-ray showing the large air shadow. So this is the dome and this much air is there. That means it's a very big perforation. You should see mainly on the right side because normally right side there is no air shadow. On the left side, there will be air shadow due to the fundal gas. Stomach will have air. So when the patient stands erect, that air goes into the fundus. So fundal gas will be there. So that's why you must always focus your attention on the right side of the dome of the diaphragm. It will accumulate on the left side of the dome of the diaphragm also, but that gets overshadowed by fundal shadow. That's why you may not be able to observe it. So you can see here, this is the air shadow. You can also see another air shadow on the left dome of the diaphragm. It is not fundal shadow. You can see here a shadow. This is the fundal shadow. Normally, the fundus must be somewhere here, but here the fundus is displaced down. You are not seeing its normal position. Can you guess what the cause? Why the gas shadow in the stomach is not, it is about few centimeters below the diaphragm. It is not exactly under the diaphragm. Why? Can you check? Just imagine and tell me. It is because not the pseudocyst will be somewhere down. It is not due to food. In erect posture, food will come into the pyloric canton. Air will go into the. This is the dome of the diaphragm. The stomach is normally here. But in this case, we are seeing stomach is somewhere here. Why? Because there is some space occupying lesion below the diaphragm. So what space occupying lesion can be there? It can be due to a carcinoma in the fundus. That is why the air shadow is seen not just beneath the diaphragm, but little below that. Or there is splenomegaly. When splenomegaly is there, spleen will push the stomach downwards. So in this case, the patient has splenomegaly. So that is why the stomach shadow is little down. So we are seeing two crescentic air shadows under the domes of the diaphragm. So here also you can see a small shadow. If shadow is not seen but the patient is having very severe pain, then you can take CT scan. CT scan gives better and accurate information about pneumoperitoneum, and also where plain X-ray doesn't show a gas shadow, then if you take CT scan, it will show the gas shadow if it is present. If gas shadow is not there, the other advantage of CT scan is you can visualize the pancreas, because such severe pain can be due to acute pancreatitis. So you can evaluate the pancreas. Then of course, in any acute abdomen, already we discussed, first you take the urine microscopy, then plain X-ray abdomen erect posture, the second one is serum amylase estimation, then you go for ultrasound scan. So these are the things you must do in every case. So then serum amylase estimation, ultrasound scan, cholecystitis, pancreatitis, amoebic abscess if there is no pneumoperitoneum. Biochemical investigations. Sodium, potassium chloride, bicarbonate, and creatinine estimation to evaluate the fluid and electrolyte balance. Treatment. The patients will be in peritonitis state. He has a lot of fluid loss, third space loss, so he must be resuscitated. The first thing is do nasogastric aspiration. You pass a Rayleigh tube into the stomach and aspirate the stomach contents to keep the stomach completely free from fluid. So if you can totally aspirate it or continue to aspirate it, what will happen? The spill into the peritoneal cavity will be very much diminished. The fluid and electrolyte balance is corrected by administering fluids and electrolytes. Patients are given analgesics. Pseudocyst won't push the stomach down. Pseudocyst will push the lesser curvature of the stomach down, not the greater curvature. Pseudocyst will push the stomach anteriorly if it is retrogastric. Pseudocyst, if it projects between the lesser sac, between the stomach and liver, then the lesser curvature will be pushed down. The fundus is not pushed down because at the fundal region, the pseudocyst will not develop. Because at that place, the tail of the pancreas is not there. Tail of the pancreas is very slender, so there is almost behind the body of the stomach, not at the fundus of the stomach. That is why pseudopancreas won't develop at the fundus of the stomach. So here in this case, what I have shown, it is not the pseudopancreatic cyst, it is spleen. Okay, resuscitation, nasogastric aspiration, fluid electrolyte balance, maintenance, antibiotics, broad spectrum, and anti-anaerobic. Surgery after resuscitation of the patient. The treatment is whenever there is a hole in the bowels, they should be closed. How do you close? Omental patch closure. Do laparotomy. You close the perforation with omental patch. Then do peritoneal toilet. Peritoneal toilet means you pour 1 or 2 liters of ringer lactate in the peritoneal cavity and aspirate all the contents. That means everything that has leaked out should be completely washed out. And after washing, you must do peritoneal drainage. That means you keep a tube in the peritoneal cavity and close the abdominal cavity. You keep the tube for about 2 or 3 days, so that if any more reactionary fluid is excluding out, it will find its way out through the drain. Wilroth 2 gastrectomy in patients with large perforations where simple closure is not possible. If you see one perforation, don't be satisfied with that. Check the second part of the duodenum also. Sometimes there may be perforation in the second part of the duodenum, which occurs usually in Zollinger-Ellison syndrome. This is how you do the omental patch closure. This is the perforation. You take underrunning sutures like this. You don't tie them. If you tie them, what happens? The edges will be very much fragile because they are all edematous due to inflammatory reaction. If you tie them, they will cut through the tissues and the opening will become still more wider. So you take the omentum, you keep the omentum over the perforation like this, and then tie them, tie the sutures over the omentum. Then there will not be any cutting through to the tissues. This omentum acts as a plug over the perforation. So you keep the omentum like this and then you close the perforation. So you can see here, this is operative photograph of a patient with perforation. You see all white flakes. These are all fibrinous flakes that are present throughout the peritoneal cavity. So you can see a small perforation here. Sutures of silk are passed through the under the perforation, just above the perforation and below the perforation also. Then the omentum is brought there and it is sutured in place. Then you take ringer lactate solution, pour it into the abdominal cavity, and you thoroughly wash and you suck away all the fluid. And again pour ringer lactate and suck it out. Like that you do it for 2 or 3 times. In fit patients, definitive procedures for duodenal ulcer like vagotomy, iontrectomy used to be done in the earlier days. But nowadays it is not being done. Our intention is only to close the perforation and to tide the patient from the emergency situation. So you are treating the complication, but the disease is still present. That means duodenal ulcer is still there. So how do you manage the duodenal ulcer? So you manage him medically later on, because we have such powerful proton pump inhibitors. So you give the patient the H. pylori treatment if necessary, or proton pump inhibitors. Gastric perforations. I told you whenever gastric ulcer is there, you must always take a biopsy. So even if it is a perforation, you must take a biopsy from the perforation margins and then suture it over the momentum. Bilirubin in patients with large perforations where simple closure is not possible. This, of course, operation can be done by laparoscopy also. The principles of treatment are same. Mortality, it depends upon the age of the patient, duration of the peritonitis, associated disease of the patient. 5 to 10%. Previously, it used to be around 20 to 26%. Follow-up treatment, the patient should be managed later with medical management. Intracorporeal suturing means during laparoscopy, you pass the instruments into the peritoneal cavity through the ports, and in the cavity you suture and place a knot. That is called intracorporeal suturing. There is one more method called extracorporeal suturing. That means you take the thread inside, pass it around the organ where you want to put a ligature, get the threads outside the abdominal cavity through the ports, form a suture loosely, and then you push the knot down into the peritoneal cavity. That is called extracorporeal knotting. Intracorporeal knotting means inside the peritoneal cavity, if you do the suturing and knotting, it is called intracorporeal knotting. So that is about the acute complication perforation. The second acute complication is bleeding from the duodenal ulcer or gastric ulcer. That is the hemorrhage. Hemorrhage manifests as hematemesis or melena and is associated with high mortality. So let us study about hematemesis and melena. Not only because of duodenal ulcer, due to any reason, if the patient vomits blood or passes black tarry stools, then how to manage this patient? If bleeding is there into the gut, how the patient manifests clinically? Let us first study that. It depends upon the site and quantity of the bleeding. Site of the bleeding. Upper GI bleed means bleeding above the ligament of Treves. What is ligament of Treves? What is ligament of Treves? If you don't know, please tell me no. Suspensory ligament where? Ligament of duodenum, no. Be specific. You are correct by only 80%. Make it a complete answer. Yes, it is the suspensory ligament of the duodenojejunal junction. So ligament of Treves means it represents duodenojejunal junction. So upper GI bleed means any bleeding occurring proximal to the duodenojejunal junction is called the upper GI bleed. It manifests as hematemesis or melena. Lower GI bleed means below that one is called the lower GI bleed. It manifests as bleeding per rectum or melena. Melena means black tarry stools is called the melena. So this is the duodenojejunal junction and this is the place of ligament of Treves. Now let's see how the bleeding into the gut manifests. Whenever there is bleeding into the stomach will be very irritated because of the bleeding, because of the blood. So there will be reverse peristalsis. This reverse peristalsis will produce vomiting. The patient will vomit coffee ground vomitus. When blood is in red in color, why the patient vomits a coffee colored vomitus? Why is it so? Why is it not red colored vomiting? What will happen due to acid? What will happen to the blood when mixed with acid? Okay, you are all imagining. You know Shalley's test. Shalley's hemoglobin estimation test. What will happen there? What will happen to the hemoglobin? You add what there? Okay, whenever hemoglobin comes in contact with acid, it becomes hematine. It is called acid hematine. Yes, it is called the acid hematine. Acid hematine is brown precipitate. So, because the bleeding occurs into the stomach containing gastric hydrochloric acid, it gets converted to acid hematine, and when the patient vomits it out, it will be coffee ground. Ground means you take coffee seeds and then ground them to a paste and add milk or water. So that becomes coffee ground. So there will be fluid, which is brown color, and with precipitate, which is brown color. That is the nature of this vomiting. So that is hematemesis. If blood is like small trickle into the stomach, then what will happen? There will not be much irritation to the stomach, so there is no reflex peristalsis. The blood passes down into the small intestine. There it is acted upon by the intestinal juices, and the protein molecules get digested. So by the digestion of the intestinal juices, the blood becomes black and sticky. This black and sticky substance passes down through the intestines and comes out as melena. This is called the black tarry stools. So if small quantities of bleeding is present in the stomach, it is passed out in the stools as melena. If large amount is passed into the stomach and the stomach is getting irritated, the patient will get hematemesis. For example, if there is bleeding in the ileum, not in the jejunum, the digestive juices gets absorbed once they come into the ileum. There are no more digestive juices. The pepsin, trypsin, chymotrypsin, etc., all are being digested and absorbed as they reach the ileum. So when the bleeding is there in the ileum itself, it is not coming from stomach, it is there in the ileum, then what happens? Let us see. There is only very small amount of intestinal juices left behind because much of them have been absorbed. The black color of melena stools is because of digestion by the intestinal juices. And what is the reaction that happens by digestion? That is a complex thing. That's why I am not telling that. Only the blood gets altered by digestion by intestinal juices and it becomes black and sticky. The hemoglobin becomes black and sticky after digestion. So that material will be passed out. That is called the melena stools. If bleeding is there in the ileum, then now these intestinal juices are very sparse. So there will be partial black discoloration and partial red color. So the patient passes out a maroon color stool. That means red mixed with black, that is maroon color stools. If the bleeding is there in the ascending colon, it passes out without the action of any intestinal juices or any hydrochloric acid. But as it passes down to the anal canal, it takes some time. So its oxygen has been lost. So it is not bright red in color. It gets clotted. So the patient passes dark colored clots or brown colored clots. If the bleeding is there in the sigmoid colon or descending colon, the bleeding will pass out as red colored clots. If the bleeding is there from the anal canal or lower rectum, the patient passes fresh blood. With small quantity, that will be like drops of blood. If large quantity, it will pass out, gush out, as if it is squirting from a syringe. Sometimes there will be huge bleeding into the stomach or duodenum. For example, a splenic artery is eroded or a gastroduodenal artery is eroded. Then patient will pass out large quantities of blood itself, not brown color, and he passes out red colored stools. That means the blood is in such a large quantity that the amount of intestinal juices needed to discolor it are inadequate. That is why the patient passes out red colored stools and red colored vomitus. So, to summarize, clinical presentation of gut bleeding, micro bleeding, that is very few or small drops of blood bleeding is there, just oozing. Then the patient will have occult blood detected by Benjamin test in the stools. Bleeding from stomach and duodenum manifests as hematemesis, as coffee-colored vomitus. Bleeding from stomach or upper small intestine manifests as melena. Bleeding from lower ileum manifests as maroon-colored stools. Bleeding from right colon manifests as brown clots. From left lower colon, bright red clots. From lower rectum and anal canal, bright red frank blood or fluid blood. Large bleeding, there is no alteration, then it's called hematochezia. Incidence of gastrointestinal bleeding, 80% they occur from the stomach, 2% from the small bowel lesions, and 18% from large bowel lesions. Causes of upper gastrointestinal bleeding, apart from peptic ulcer, there are other conditions which can cause gastrointestinal bleeding. Of course, these three are the peptic ulcer. And apart from peptic ulcer, other things being, that means superficial mucosal erosions. That can be in the esophagus, stomach, or duodenum. Then there is a condition called Mallory stare. Then esophageal varices. Then Gave syndrome. That means gastric antral vascular ectasia. Ectasia means dilatation. So antral vessels have been dilated. So sometimes the vessels in the antrum are so much dilated, so they will be seen like this as red streaks in the mucosa. So this gives something like a watermelon stomach. This is also called watermelon stomach. On endoscopy, you will see mucosal streaks of dilated vessels like that in the watermelon. So if you look at these causes, the commonest cause of upper GI bleeding is peptic ulceration. And in this peptic ulceration, the commonest is from duodenal ulcer. It is not esophageal varices, because many students, they mention what the commonest cause of upper GI bleeding, they mention esophageal varices. That is incorrect. So commonest cause is peptic ulcer. Next cause is erosions. Then the minor causes like tumors, vascular lesions. There is example Julophy's disease. That means some vascular malformations in the submucosa of the stomach and duodenum also can cause the upper GI bleeding. Then miscellaneous causes like hematobilia and coagulation disorders, they account for about 5%. What is hematobilia? Hematobilia. We have discussed this topic. I told you that this is a short notes question also. What is hematobilia? In which condition you find hematobilia? In which condition you will find hematobilia? Okay. Okay, I will explain once again. Hematobilia means if there is a small tumor in the liver, the tumor ruptures into the adenomas and carcinomas, they can have spontaneous bleeding. So if they bleed into the peritoneal cavity, the patients will have hemoperitoneum. Sometimes they bleed into the bile ducts. When it ruptures into the bile duct, then what will happen? The bleeding will be there into the bile duct. So the blood flows through the bile duct, then blood enters through the papilla of water into the duodenum. Then patients vomit it out. So the vomiting is vomiting of blood, but the blood is originated in the biliary tract. So that is called hematobilia. So hematobilia means bleeding into the biliary tract due to any cause will manifest as hematemesis. That is hematobilia. That may be commonly due to tumors like hepatic adenomas, hepatocellular carcinoma, and sometimes due to trauma. So out of so many causes, the most common causes being peptic ulcer, erosions, Maldives tear, and varices. Management of hematemesis. So the patient has come to you with vomiting of blood. How do you manage? First, you resuscitate him if he is in hypovolemia. Then you diagnose what is the cause for this bleeding. Then you give the treatment necessary for that particular disease. Resuscitation ABCD, airway maintenance and breathing assistance, then circulatory assistance. That means his hemodynamic status should be corrected. First, you pass in an intravenous line, take blood for cross-matching, hemoglobin percentage, PCV, creatinine, and coagulation profile, and for blood transfusion. And then give blood transfusion. Monitor the patient for CVP, urine output, vital parameters. Then disability assessment. So this is the resuscitation you do for any patient coming with bleeding. Already we discussed these points when we discussed about the shock. Hypovolemic shock, then there we have discussed these resuscitation principles of management of shock. Diagnosis, once the patient is resuscitated, you do upper GI endoscopy. So this is performed as soon as the patient is resuscitated to diagnose the site and cause of the bleeding, the stigma of rebleed. The meaning of that I will tell you in the next slide. So once you do endoscopy, you will find for example, peptic ulcer. The peptic ulcer is bleeding. So don't stop there. You just closely focus the ulcer and see for these things. Presence of a blood vessel in the floor of the ulcer. If you see a small pulsating blood vessel in the duodenal ulcer floor, that means it is gastroduodenal artery. Or if you see a vessel which is spurting, that means blood is coming from an artery. Or there is a big clot in the floor of the ulcer, that means there was a large bleeding temporarily stopped by clots. So when these things are present, means these patients will have rebleed again. So these are called the stigma of rebleed. So the upper GI endoscopy is not only for diagnosis of the cause of bleeding and stigma of rebleed, but also to stop the bleeding. Of course, before you do endoscopy, the oral cavity and throat should be examined to exclude any bleeding from these sites. Sometimes patient may be having nasopharyngeal fibroma and he may be bleeding. So he may not bleed outside. He will swallow all the blood that is coming there. So the blood goes into stomach and the blood is vomited. The patient comes to you with hematemesis. You will think that it is a case of gastric problem, some disease in the stomach or duodenum. But the fellow's problem is there in the posterior nasopharynx. So before you do endoscopy, you put a torch in the throat and nose and then check if there is bleeding from the nose or the throat. Because some individuals, when small amount of bleeding is coming, they just simply gulp it. The blood goes into the stomach and then it irritates and the patient vomits out the blood. So you will mistake it to be a hematemesis. So that will be a grave mistake on the part of the surgeon if he misses that. So he will be going to land in a great problem. So upper GI endoscopy is done for diagnostic and therapeutic purpose. So you will see blood like that flowing from the ulcer. This is a stigma of rebleed. You can see here a spurting blood vessel, and you can see a visible vessel. Treatment depends upon the type of lesion. If the bleeding is from a peptic ulcer, how do you manage it? The most common complication of peptic ulcer occurs usually in older people. The NSAID consumption again is the main cause here for the bleeding because of back diffusion of acid. Already I discussed it in the previous class. Or a large vessel may be eroded by the ulcer. So erosion of splenic artery by gastric ulcer, and duodenal ulcer can erode into which vessel to produce massive hematemesis? Duodenal ulcer I am talking. Fatima, you said it is splenic artery. Splenic artery is for the gastric ulcer. For duodenal ulcer, it is the gastroduodenal artery. Yes, it is the gastroduodenal artery. You are right now. So erosion of gastroduodenal artery by a posterior duodenal ulcer. So how do you manage? Medical treatment has little efficacy. Medical treatment means proton pump inhibitors, etc. But it forms the first line of treatment before other modalities of treatment are instituted. It is given in concurrence with resuscitation. So when the patient comes to you with hematemesis, you start him on IV fluids and blood transfusion, and along with that, you administer him the omeprazole or pantoprazole intravenously. So parenteral administration of H2O receptor antagonists or PPIs. Then you give tranexamic acid, which is fibrinolysis inhibitor, that is very helpful. Then you can give octreotide, that is somatostatin, which will depress the gastric secretion. So our principle is to reduce the acid secretion. Then do the endoscopy. So if bleeding is there, you stop the bleeding by laser or organ beam coagulation, or by application of hemoclips, or by injection of 1 in 10,000 adrenaline around the ulcer base and into the floor of the ulcer. Or you can apply a heat probe, that's called a diathermy probe, is applied to the area that causes coagulation of the proteins there and seal the bleeding vessel. So you do one of these things, but commonly practiced procedure is injection of 1 in 10,000 adrenaline around the ulcer base and into the floor of the ulcer. By vasoconstriction action of the adrenaline, the ulcer, so the blood vessel will go into constriction and bleeding will be stopped. Surgical treatment indications: continuation of bleeding in spite of the endoscopic procedures, a patient who needs more than 6 units of blood in 24 hours is a sure candidate for surgical treatment. That means he is bleeding continuously in spite of the endoscopic maneuvers. And to tide over the hypovolemia, you are transfusing and you have already given about 6 units of blood. That means don't still waste your time by doing a repeat endoscopy. If such large amounts of bleeding is occurring from the ulcer, means it is better to go for surgical procedure. Or if you find the stigma of rebleed, that means spurting vessel, clot, or visible pulsating vessel in the floor of the ulcer, then go for surgical maneuver. In elderly and old people also, the decision to operate should be taken early in this group before the irreversible hemodynamic changes occur due to continued bleeding. Duodenal ulcer surgery. The aim of surgery is to control the bleeding. What you do? First, cauterize the duodenum, then do pylorodduodenotomy. See the bleeding vessel, underrun the vessel with well-placed sutures. Then close the duodenum like pyloroplasty. This is how you do cauterization. Already I told you, but again I am repeating here. Cauterization is nothing but cutting the peritoneum along the convex border of the duodenum. It is called the cauterization. So for that, the duodenum must be completely exposed. So how to expose the duodenum? This colon is there in the middle. So you cut this is called phrenicocholic ligament. So cut the phrenicocholic ligament. The hepatic flexure can be pushed down. Once it is pushed down, then the whole duodenum can be visualized. Then you incise at the convex border of the duodenum. This is called cauterization. So with that, what happens? The duodenum can be mobilized. So once you incise this peritoneum, you can separate the duodenum and pancreas from the posterior abdominal wall. So once the duodenum is there in your hand, it is easy to maneuver it. Then you do pyloroplasty operation. You make an opening 2.5 centimeters on the duodenum and 3.5 centimeters on the antrum. Do pylorectomy. See the bleeding vessel, some bleeding. Then you underrun the sutures and tie them. The pulsating artery is there. You ligate it at 3 points, one above, one ligature below, and third ligature is towards the right, because there is transverse pancreatic artery. So these 3 must be applied. Then close the duodenum vertical fashion. That is the pyloroplasty operation. Different surgery for duodenal ulcer like vagotomy can be done in fit and young individuals. Later, all the patients are managed medically. Surgery for bleeding gastric ulcer. Do laparotomy, do gastrotomy, means you open the stomach, take biopsy from the ulcer margins, then underrun the bleeding vessel on the floor of the ulcer. Billroth-1 gastrectomy can be done, but In a patient who is bleeding and in a bad state, if you do bilirubin gastrectomy, the complications rate and mortality will be high. That is why it should not be done. Angiography and therapeutic embolization. A patient comes to you with hematemesis, but on endoscopy, you are not seeing any lesion. But patient, you have seen him vomiting blood. But when you resuscitated and then did the endoscopy, stomach and duodenum are completely normal. Then what it could be? I already told you. Some conditions will manifest like that. Tell me what lesions can cause such type of orientation. Endoscopy normal. Patient comes to you with massive hematemesis. No, nasopharyngeal fibroma already you excluded before doing endoscopy. It is not there. No, there are no ulcers on upper GI endoscopy. Stomach and duodenum were normal. It is due to AV malformations. Erosion means ulcer should be there to erode, but there is no ulcer here. Whenever you see a normal stomach on endoscopy for a patient with hematemesis, so you should suspect a arteriovenous malformation. So there will be dilated vessels with thinned out walls. So they bleed. And when they stop bleeding, the mucosa is perfectly normal. So that's called the arterial and venous malformations. That usually occurs in past elderly age group. So in such cases, you do celiac angiography. Source of bleeding cannot be ascertained. So indication. Do celiac angiography. You see the bleeding point there or ectatic vessel and do therapeutic embolization. The mortality for bleeding peptic ulcer will be around 6 to 7%, but it will be more in elderly persons. The other bleeding lesions in the stomach and duodenum are the erosions. The erosions are mostly because of NSAID usage. Usually the bleeding stops spontaneously. Treatment is endoscopic methods are usually successful. If they fail, surgery is done. Surgery is underrunning of the bleeder. Gastrectomy, then rarely if the diffuse bleeding is seen from the stomach. Stress ulcers, already we discussed. Stress ulcers can be prevented by giving proton pump inhibitors and ranitidine, sucralfate prophylactically in patients with major trauma and major surgery. Considered treatment usually successful with proton pump inhibitors and rest to the patient. Not successful, then you go for endoscopy. Then surgery, do gastrotomy or duodenotomy and then underrun the bleeding ulcers. Malarious tear. Repeated and strenuous vomiting produces a longitudinal tear on the mucosa just below the gastroesophageal junction. So there will be a tear on the stomach on the lesser curvature side just below the gastroesophageal junction. Treatment, endoscopic methods, that means injection of adrenaline. If it's not successful, do surgery, that means do laparotomy, do gastrotomy, then underrun the bleeding tear. So the tear should be sutured. Gastroesophageal varices already we have discussed. Physical methods, there is Sengstack Blackmore tube. Pharmacological methods being octreotide, glycipressin. Glycipressin means vasopressin means glyceryl trinitrate. Endoscopic treatment means sclerotherapy and banding. Then surgical methods carries high mortality. Procedures: Siguri operation, emergency shunt operations, TIPS operation. So already we have discussed these things in detail. The Joulefoy's disease. This is the vascular malformation. This is an AV malformation in submucosa. This lesion appears only at the time of bleeding, and hence it is very difficult to detect these lesions. So once the bleeding stops, the lesion is not seen. As the bleeding occurs, then also you don't see any lesion there. You see just pumping of blood. Treatment, endoscopy treatment. If you can find the lesion while you are doing endoscopy, you can do sclerotherapy. You can do local excision of the lesion if you know this lesion, if endoscopy is unsuccessful. And gastrectomy in difficult cases. You can do therapeutic embolization after angiography, and you can close the dilated vessel. So this is how the Joulefoy's lesion appears. There will be just oozing of blood through a small opening in the mucosa. Once the bleeding stops, this mucosal opening also is not seen. Bleeding neoplastic lesions. Leiomyoma of the stomach commonly manifests with bleeding, rarely from other benign and malignant tumors of the stomach. Treatment: treat the tumors. Aortoenteric fistula. Sometimes the aortic aneurysm ruptures into the abdominal viscera, or it follows aortic graft. It gives way. Bleeding may be mild or torrential. Investigation: CT scan. Treatment: vascular surgery of the aorta. Mortality will be very high in these cases. So this completes the topic on the other acute complication of peptic ulcer, namely the bleeding. So we have studied about the management of peptic ulcer, management and presentation of the acute complications, namely the perforation and hematemesis. Then we are left with chronic complication, that is the narrowing. So we will study it in the next class. So in the next class, we will go with the duodenal stenosis, then neoplasms, then the post-operative gastric operative sequelae. So after doing gastric surgeries, patients will get a lot of sequelae. So we'll study about those sequelae and complications. So this is about the next classes. So we will have about some 2 or 2.5 classes. Not 2.5, it will be, yes, 2.5 classes. So tomorrow also there will be class. I will put the details about the class on the website today evening or tomorrow morning. Please check that. Do you have any doubts? If you have no doubts, I will close this session. Okay, thank you very much. Wish you all good night. See you tomorrow. You want vagotomy slides? Do you want me to show now? Okay. So others can leave, no problem. Just I will show the vagotomy slides to the student. Okay, vagotomy is of three types: the truncal vagotomy, selective vagotomy, and highly selective vagotomy. If you transect the main vagus nerve before it gets branched, it is called truncal vagotomy. Yes, this videos will be posted after some time. Just I am working on that because it needs a lot of editing. I'm not finding time to do this job. So once I edit them, then I will post them. Already some videos are there in the YouTube. You can go through those videos. But for the past classes, it will take some more time. So the truncal vagotomy means it is a sectioning of the vagus nerve before all the branches are given out. By that, the stomach gets denervated, as well as the other abdominal alimentary tract organs also are denervated from the vagus. So patient will have the diarrhea. Post-operative diarrhea will be there, and because gastric motility is affected, patient needs a drainage operation like gastrojejunostomy and pyloroplasty. So this is truncal vagotomy. Selective vagotomy. That means the branches which go to the stomach only are cut. That means the nerve of Latarjet is cut. The branches that goes to the celiac plexus is preserved. So the post-vagotomy diarrhea is absent in this case, but patient needs a drainage operation to drain because stomach becomes atonic. Highly selective vagotomy means the vagal branches going to the secreting part of the stomach, namely fundus and body. They contain the parietal cells. They secrete acid. So you section only those nerves. Leave behind the nerves which are supplying the pyloric antrum. Then this is called the highly selective vagotomy. So the highly selective vagotomy is to denervate the stomach, body, and fundus. Pyloric antrum is preserved. Because antrum is preserved, the motility of the stomach is preserved. So this doesn't require a drainage operation. When drainage operation like gastrojejunostomy or pyloroplasty are not present, the normal activities of the stomach and duodenum and normal pathway of food passage will be there. So postoperative sequelae or morbidity is very much less with this particular procedure. So this is called the highly selective vagotomy. This can be done by open surgery or by laparoscopy. So that is about the vagotomy. I hope you understood this point. Okay. So if there are no more doubts, I will close this session. Okay, bye. Wish you all good night. Thank you.